Hello, and welcome to the third presentation in this recorded presentation series, Tobacco Cessation Coverage in Medicaid, What You Need to Know. Your presenter today is Jennifer Singletary, the Director of National Health Policy at the American Lung Association. Jennifer, over to you.
Thanks, Anne. In this presentation, we will talk briefly about what is Medicaid and what is Medicaid expansion, and then we'll talk about what tobacco cessation treatments are required to be covered in both types of Medicaid. Before I start, I want to define my acronyms that I'll be using throughout this presentation. The first one is the ACA, which stands for the Affordable Care Act, Healthcare Reform, Obamacare, whatever you'd like to call it. HHS is the U.S. Department of Health and Human Services. That is the main federal agency implementing the ACA. CMS, Centers for Medicare and Medicaid Services, that's the main sub-agency under HHS that is implementing a lot of the coverage requirements that we'll be talking about, as well as many other parts of the ACA. An SPA, or SPA, is a state plan amendment. These are documents that Medicaid programs submit to CMS that essentially change their policies and their structure. And the last one is the USPSTF, which stands for the United States Preventive Services Task Force, and I'll get into what that is later on. So what is Medicaid? Medicaid is a federal-state partnership program that provides health insurance to low-income and disabled Americans. Medicaid is not new with the Affordable Care Act. It existed long before, was created many decades ago. The funding for this program is joint. It comes from the federal government and state governments. The percentage of funding varies depending on the state. The federal government reimburses state Medicaid programs through the FMAP program, and the percentage that it reimburses is dependent on a formula that is based on how many low-income citizens are in that state and would therefore be in need of Medicaid. Each state can set its own eligibility requirements for Medicaid. There are some required categories that all states, if you want to do a Medicaid program, you have to cover a certain categories of citizens, but then beyond that, states can decide whether they want to cover more people, up the income scale, other categories, pregnant women, childless adults, those types of categories. And then the last thing to note here is that this Medicaid that was in existence before the Affordable Care Act is what is now called traditional Medicaid, and that is opposed to Medicaid expansion, which I'll explain. So what is Medicaid expansion? Well, Medicaid expansion was created by the ACA, so it's new as of 2014. It is funded fully by the federal government for the first several years. And then after those years, the federal government share goes down some, but not that much. Still, most of the funding going to covering the Medicaid expansion population will be the federal government until that changes, until Congress changes that. Medicaid expansion is meant to cover the population that makes too much money to qualify for traditional Medicaid, like I just talked about, up to 138% of the federal poverty level. And you can see that 138% is equal to just over $16,000 annually for income for one person. And then, of course, the income level goes up for families with more than one person in them. But still, we're not talking about a lot of annual income here. And the Medicaid expansion will mostly include a lot of adults that could not qualify before, perhaps because they didn't have children. It's easier to qualify for traditional Medicaid if you have dependent children. So a lot of the Medicaid expansion population is going to be childless adults. As you may have heard, in 2013, the Supreme Court released a really important case, especially for Medicaid expansion, that essentially made expansion optional for states. The ACA was set up assuming that every state would expand Medicaid, that it would not be optional, that it would be mandatory. The Supreme Court changed that and made expansion optional. And as I've been referring to it on this whole slide, the newly eligible Medicaid enrollees since 2014 tend to be called the Medicaid expansion population, or new Medicaid enrollees. If you're watching this presentation and you don't know if your state has taken the option to expand Medicaid, a good place to look for that information is the Kaiser Family Foundation. They have a lot of great information about healthcare reform and Medicaid expansion. So I suggest you go to kff.org/Medicaid, and you can find out if your state has expanded Medicaid or if that's in the works. Many states are still, past 2014, are still looking to expand Medicaid, so you can find out what's going on in your state through that website. One last concept to understand about Medicaid is the difference between fee-for-service and managed care. Now, this concept applies to whether you're talking about traditional Medicaid or Medicaid expansion. Fee-for-service is the traditional way that Medicaid programs have been structured. That is when a Medicaid program will pay for every service rendered. So every healthcare or medical service, they pay the provider directly. So the reimbursement goes directly to the provider, and that is how they pay for the healthcare coverage. Now, managed care is an innovation that came in around the 1990s, and some states started implementing managed care systems. And that is when the state Medicaid program contracts with a health insurance company. Sometimes it's your regular health insurance company like anyone else would have, like an Aetna or a United Healthcare. Sometimes there are more nonprofit organizations that provide managed care programs, and they provide them exclusively to Medicaid. So there are some different types of programs to be contracting with, but essentially it's an insurance company who says, we will insure this group of Medicaid enrollees if you pay us this lump sum, for each patient that we're enrolling in our program. So instead of paying for every service directly to the provider, the Medicaid program is paying the insurance company a lump sum to basically insure this person, this Medicaid enrollee. And then, of course, the managed care does their own reimbursement to healthcare providers. So the payment goes to the insurance plan rather than directly to the provider. Some people think that this is a money saving option because the incentive for the healthcare provider is to save their managed care company money, as opposed to ordering lots of tests and lots of services because they get reimbursed money every time they provide a service. So that is why managed care plans are supposed to have incentives to keep costs down, which therefore reduces costs in the Medicaid program. The reason this distinction is important here is who has control over the coverage being offered in these various program structures. So under fee-for-service, it's the Medicaid program that is administering the coverage. So they have total control. They can decide we're not going to cover this or we are going to cover this. It's sometimes fairly easy to make coverage changes because they have total control over what is being offered to their Medicaid enrollees. If a state has a managed care system set up, so they have, say, 10 different managed care plans providing coverage to various enrollees, that makes it a little harder to make changes that go throughout the Medicaid system. So some Medicaid programs don't feel like they have a lot of control over the coverage being offered to their managed care enrollees. I would say that's not true. They still have control over the coverage offered. They just control it in a different way, meaning that they're still purchasing services from this managed care company, and they need to spell out what coverage is being offered through the contract process. So that's how a Medicaid program controls the coverage offered to managed care enrollees. Now, this comes into play because we'll be talking about coverage requirements. These are two ways that coverage requirements get implemented in the coverage that the patient actually sees. So why is it important to be talking about Medicaid and tobacco cessation? Well, we know that the smoking rate in Medicaid is higher than the general population. You can see here, these are data from 2012, and they show that the general population smokes at a rate of 18%. Folks who are enrolled in Medicaid smoke at 30%, and the uninsured at the time, which we would assume some of these folks that were uninsured in 2012 will be coming onto the Medicaid rolls through Medicaid expansion in 2014. So we assume that population, is some folks who are now on Medicaid. The uninsured smoked at a rate of almost 30%. So we expect the smoking rate in Medicaid to increase as Medicaid expansion happens, and it was already higher than the general population to begin with. Additionally, of course, Medicaid is taxpayer funded, federal and state government funding. So nationally, Medicaid spends more than $40 billion, billion with a B, on healthcare for smoking-related diseases every year. And that is more than 15% of total Medicaid spending. So tobacco use takes a huge toll on Medicaid and on our economy, and that is why it's really important to help smokers on Medicaid quit. Now that we know what Medicaid is and what Medicaid expansion is and why we should be helping folks on Medicaid quit smoking, let's talk about what is required for these plans offered to Medicaid enrollees for tobacco cessation. There are three major requirements related to Medicaid and tobacco cessation to talk about here, and they all come from the ACA in some shape or form. The first one is under traditional Medicaid, the requirement for comprehensive tobacco cessation benefit with no cost sharing for pregnant women. And there's also a requirement for coverage of tobacco cessation medications for the whole population. Additionally, I'll also talk about the requirement for Medicaid expansion of covering tobacco cessation as a preventive service. First up is the requirement that was implemented first, which is the requirement for cessation coverage for pregnant women on traditional Medicaid. That requirement comes from Section 4107 of the ACA and says that each Medicaid program has to cover a comprehensive cessation benefit for pregnant women with no cost sharing. Cost sharing means a copay. Particularly on Medicaid, there isn't as much co-insurance or deductibles. We're mostly talking about copays when we talk about cost sharing. So that's, a $2, $3 that they're supposed to pay at the pharmacy or at the doctor's office, wherever they're getting treatment. For pregnant women, most copays are waived already, but just in case they weren't, the ACA requires tobacco cessation treatments to be provided with no cost sharing. These treatments include all 7 medications that are FDA approved for smoking cessation and individual, group, and phone counseling. So those are all the treatments that are known to be effective for smoking cessation. And these are all required to be covered for all pregnant women in Medicaid, regardless of whether they're in the fee-for-service plan or the managed care. Everyone is supposed to get this benefit as a pregnant woman on Medicaid. Now we'll talk about the requirement for tobacco cessation medications. Now this requirement applies to everyone on Medicaid, so not just pregnant women, but everyone, all adults, all smokers who want to quit. Previously, Medicaid programs were allowed to exclude tobacco cessation drugs from coverage, but that stopped with the ACA. Section 2502 of the ACA removes tobacco cessation drugs from the excludable list. So they are no longer able to exclude any of the drugs, and we're talking prescription and over-the-counter, from their coverage. That was as of January 1st, 2014. And CMS asked states to submit state plan amendments reflecting this change in policy. They were supposed to submit them as of March 2014. I'm not sure that every state met that deadline, but those plan amendments are coming in. So the wording here is a little tricky. I said that tobacco cessation medications are no longer able to be excluded. That's a double negative, and I know that's a little confusing, but that's how the law is written now. So they're not able to exclude medications. Does that mean that they have to cover the medications? Well, it should, and CMS is interpreting it that way, that states should be covering each of the 7 FDA-approved smoking cessation therapies. What does this mean in practice? States are still allowed to use preferred drug lists and formularies as they've been using for years and years. And just because they're not able to exclude a medication anymore does not mean that they have to add that medication to the formulary or the preferred drug list. So there's still some major potential issues here. If you've ever, as a patient in your own health insurance, if you've ever needed a medication that was not on your preferred drug list, you know how hard it is to navigate that and actually get the drug that you want from your health insurance company paid for. Another potential issue is the managed care plans versus fee-for-service. A lot of state Medicaid programs watch they have full control over their fee-for-service plan, and so they might implement these changes in fee-for-service, but they feel like they have less control over managed care. So another thing that's really key is to watch that all the managed care plans in a state also follow this requirement, which does apply to them, to be covering all the cessation medications. Cost sharing and other barriers and limits still are allowed. And remember, we're talking about not the pregnant women population, which cost sharing is not allowed, but for all other cessation treatments. Cost sharing is still allowed, as are other barriers like prior authorization or limiting how long someone can take a medication or how often they can try to quit per year. All of those limits and barriers are still allowed under this policy. So there's still a lot of work to be done. And lastly, a major issue is getting state Medicaid programs to reflect this coverage in their materials. If it's not in the member handbook, if it's not on the preferred drug list, if it's not in the provider handbook, how is anyone going to know that this medication is now covered as of January 1st, 2014? So it's a really important thing for Medicaid programs to change their materials and get the word out there that these medications that will help people quit are covered now. And lastly, just to mention, I've just been talking about medications, but counseling is also a very important part of quit attempts and will help patients be more successful in quitting. Unfortunately, there are no requirements right now in Medicaid for Medicaid programs to cover cessation counseling for non-pregnant adults. Now that I've talked about requirements in traditional Medicaid, I'll talk about the requirements for Medicaid expansion plans. And remember, these are the newly eligible folks under the ACA as of January 1st, 2014, in states that expanded by then, or when states decide to expand, they will have this Medicaid expansion population. Now, this slide vastly oversimplifies a lot of complicated policy, but you don't need to know all those complicated regulations and rules. All you need to know is this. So, plans that are offered to the Medicaid expansion population are called alternative benefit plans. So that's a buzzword to know. If you're talking about Medicaid expansion and someone says that phrase, that just means that it's a plan offered to a Medicaid expansion enrollee. Alternative benefit plans have to cover the essential health benefit. It's another buzzword or buzz phrase. And the essential health benefit is a minimum standard of coverage requirements in various types of plans. And there are requirements for the types of coverage in the essential health benefit that come from the ACA legislation. Again, I won't get into all the details there. All you need to know is that the essential health benefit includes, as required coverage, all preventive services given in A or B by the U.S. Preventive Services Task Force. That's that bad acronym from the beginning of the presentation, the USPSTF. The USPSTF is a group of experts that gives recommendations on preventive services for clinicians, and now they've been roped into insurance policy as well. But they basically look at the various types of preventive services and give recommendations on which services are worth doing for a certain population. They weigh the costs and the benefits and come up with these recommendations. So tobacco cessation is given an A recommendation by the USPSTF. So that means they say that the cost of performing this preventive service is outweighed by the benefits, and that clinicians should be providing tobacco cessation interventions to all adults and all pregnant women. So what does all that mean? Well, that has been a question for several years after the ACA passed. Tobacco cessation, the recommendation for tobacco cessation from the USPSTF did not translate easily into insurance policy. It said tobacco cessation is effective and clinicians should be doing these interventions, but it didn't say that means insurance companies should cover XYZ. It didn't spell out what the actual coverage requirement should be. Thankfully, in May of 2014, the departments implementing the ACA released some guidance on this. So some further clarification in the form of an FAQ, a frequently asked question. It was released by the Departments of Health and Human Services, Labor, and Treasury. Those are the folks implementing the ACA. And you can see the number of the FAQ here. They release these FAQs all the time. And this particular one was about preventive services and tobacco cessation. Just know if you go to look for the actual FAQ and you get to the page, you have to scroll down to question 5. Otherwise, you're going to think you're in the wrong place because it's talking about something not related to tobacco cessation. So scroll down to question 5 and you'll see the relevant text there. So what did the guidance from HHS and the other agencies say? So the guidance basically lays out what plans should be covering for tobacco cessation as a preventive service as part of that essential health benefit Medicaid expansion requirement. So the guidance said that plans should be covering at least 4 sessions of individual, group, and phone counseling, at least 90 days of all the FDA-approved smoking cessation medications when prescribed, and they have to be prescribed because that's the only way insurance can cover it. But that includes over-the-counter medication. So the patch, the gum, and the lozenge are all over-the-counter, but they are included in this requirement. The plan should also be covering at least 2 quit attempts per year. The guidance reiterated what the legislation said in saying that this benefit should be covered with no cost sharing, so no copays for anyone. And it also said that there should be no prior authorization requirements. Prior authorization is when a patient or a doctor has to essentially ask the insurance company or the Medicaid program for permission to administer a treatment. So before you can get this drug, the insurance company has to be contacted and they have to say, okay, they're allowed to have this treatment. Prior authorization can really slow down the quitting process, and quitting is very motivation oriented, and anything that slows that down can really discourage a smoker who maybe was motivated before, but now it's taken them a week to get this medication or this counseling scheduled, and now they have relapsed and they are just smoking again. So prior authorization can be really a problem, and so this guidance says that these plans should be offering this benefit without prior authorization. So Medicaid expansion plans should be offering a comprehensive tobacco cessation benefit to the new Medicaid expansion enrollees. And as we talked about before, traditional Medicaid should be offering a comprehensive benefit to pregnant women with no cost sharing, and then also all the medications to everyone else on Medicaid. So the requirements for the three different things are a little bit different, but they all amount to offering a pretty robust benefit to Medicaid enrollees. That is the requirement anyway. And we just wanted to mention this last slide where if a state is combining their two populations, which many of them are doing. So you've got traditional Medicaid, you've had that for decades. The state has decided to expand Medicaid. So now you have this new population of people in Medicaid. And there are different requirements, not just on tobacco cessation, but on a whole host of other things. There are different requirements for coverage for those two populations. But many states are electing to throw the two populations together, provide them with the same plans, basically just incorporate the Medicaid expansion population into already existing Medicaid. Now, that is a very good idea in most cases because it prevents a lot of confusion on the part of patients and doctors and the people administrating Medicaid. It's hard to keep track of whether you're expansion or traditional. You might fluctuate between the two. So it's a lot easier to just put everyone together in the same program, which is what a lot of states are doing. The challenge is that you've got different requirements for the different populations. And the one that is particularly relevant here is that cost sharing, and remember, cost sharing is copays, that amount of money that you have to pay when you fill a prescription or go to your doctor. So cost sharing is allowed for tobacco cessation in traditional Medicaid. So if you're not pregnant, if you're a non-pregnant adult in Medicaid, in traditional Medicaid, the state is allowed to charge you a copay. It is not allowed to charge you a copay for tobacco cessation if you're Medicaid expansion. So if you're one of those new enrollees, this can get very confusing. And the Lung Association's recommendation is if a state is incorporating their expansion population into the traditional population, the easiest thing for everyone and the right decision is to simply get rid of copays across the board. If the state has already been charging copays for traditional Medicaid, just get rid of those copays so that you don't have to figure out who is expansion and who is traditional, and so that you won't be putting up that barrier for these very low-income folks who can't afford a lot of things and maybe can't afford the copay. So our recommendation is to standardize everything and get rid of the copay for everyone.
Thank you, Jennifer. We have a couple questions now. First, what if my state didn't expand Medicaid? What happens? Is there a chance they could in the future?
Yes, that's a good question. And states, there is no deadline for states to expand Medicaid. The law was set up so that with the idea that they would all be expanding Medicaid as of January 1st, 2014. But that does not mean that a state who hasn't expanded can't expand later. So there is no deadline. States are still, post January 1st, 2014, states are still debating whether to expand Medicaid as applicable. And there isn't a deadline. States can still expand whenever they are ready.
Thank you. So the next question is, how would a patient get over-the-counter medications covered by Medicaid?
Another good question, and one we commonly get. Medicaid programs do generally cover some over-the-counter medications, including tobacco cessation medications like the nicotine patch gum and lozenge. The one complication is that the patient needs to go get a prescription from their healthcare provider. So they basically treat it like a prescription-only drug. Because otherwise Medicaid wouldn't know whether they were supposed to pay for that drug. So you need that prescription, but then it works just like any other drug you'd be filling at the pharmacy through Medicaid. So the patient just needs to go and get a prescription from their healthcare provider, and then it'll work the same way as any other drug.
Thank you for watching this online presentation today. If you'd like to learn more, please go to www.lung.org/cessationTA. If you have more specific questions, please contact Jennifer or Ann at the email addresses shown. We hope that you will watch the other 4 presentations in this series. Thank you, and we hope to see you soon.